So the signs of hip and knee arthritis are mostly associated with pain related to activities. For example, if you are able to walk a couple of miles and now you are not able to walk a couple of miles and you have hip pain, that is groin pain or knee pain. So one is pain related to activities. The other is pain at night. Arthritic pain mostly comes at night when your brain is not distracted by other things. It is like a dull, aching pain which is there all the time. In knees, you might find swelling, and you might also find that they could be your leg could be slightly bored, and in hips you might find that you're limping, and your gait has changed. Your dear ones and near ones might say to you that the way you're walking is not correct. And you might also find some shortening of your leg in relation to hips. So in summary, it is pain related to activities, pain at night, stiffness, swelling if it is related to knee, and a change of the way you walk, or your gait pattern might change. These are the main signs and features of osteoarthritis. So if you have hip or knee pain which is related to arthritis, you should always do the simple things, that is rest, elevation, if it's related to knee, and if it's related to swelling, anti-inflammatories if you're allowed to take them, to activity modifications, and see if the symptoms get better. If after these changes, if your symptoms are still not getting better, then it is the time to see an orthopedic surgeon. You can see a physio first and then see an orthopedic surgeon, or you can see an orthopedic surgeon, get a diagnosis, and then go to physio if that is appropriate for you, for your treatment pathway. So the surgical options available if it is related to knee arthritis can be various options. I always take patients to the NICE guidelines and give them a step-way approach to it. The step-way approach would be activity modification, anti-inflammatory, brace. You can have steroid injections. A lot of patients ask me about various other forms of injections like PRP and arthrosamide. I do take them through the NICE approved guidelines and what the research is based on each of them. And if none of them help, then you can think in terms of a hip replacement or a knee replacement or a partial knee replacement based on where the symptoms are. A surgical option in a hip and a knee arthritis in terms of a replacement surgery is not something which one should take lightly, and a lot of consideration and thought has to be given to it by the patient as well as the surgeon before embarking on that journey. Right. So a knee replacement is a very big operation. I will divide that into partial knee replacements and full knee replacements. A partial knee replacement can be half your knee replacement, or just resurfacing your patella, of what we call the patellofemoral replacement. I'll start with the knee replacement. Knee replacement is quite an involved surgery. I always tell patients 50% is my job, 50% is your job. You will have a bit of stiffness and swelling for about 6 months to a year, and you'll have to do a lot of physio. You can do it yourself, but there's a lot of commitment from your side to get the knee better, because after a knee replacement you might go through a phase of stiffness and pain, and it is breaking that pain barrier and increasing the range of motions that is very important. If you're talking in terms of a partial knee replacements or a patellofemoral replacement, is slightly more easier, and the process could be faster. Sometimes half a knee replacements I do as a day surgery list, replaced, and they're pretty much back to doing most things by about 6 weeks to 3 months. When I say most things, I'm talking about moderate level of activity levels of what they were before. Of course, one has to also consider the risks of a knee replacement. The risks are infection, bleeding, nerve damage, stiffness, chronic regional pain syndrome, and DVT, if it leads on to pulmonary embolism, could be fatal. Though the risks are less, about 5% altogether, but still there is risk associated with any form of big replacement surgery, like a knee replacement or a partial knee replacement surgery. But the most important thing one has to understand is about 80% of patients are happy with the total knee replacement, and 20% of patients are unhappy with their knee replacement. I do robotic surgeries. It's early days. We probably will have to do it for 10-15 years to find out if there is a palpable difference in the outcome. My initial data shows that there is some difference, but we will have to wait for 10-15 years to come to a definitive conclusion on that. For partial knees or PFJ knee replacement, I certainly do all of them robotic. For a full knee replacement, I give the patients a choice. I'm not saying robotic surgery or navigation surgery is a panacea of reducing the post-operative stiffness or pain, but it helps, at least in from what I have seen. So a partial knee replacement is advantageous because, as the word says, it's a half a knee replacement, so you can get over the surgery faster. You're not cutting your ACL or your PCL, hence you will feel that it is not a tin knee, and to an extent it will almost be the same, almost feel as if it is your normal knee, and to an extent your activity levels or the expectations could be matched up with a partial knee replacements in most cases. The disadvantages are, see, arthritis is a progressive condition. So as arthritis progresses in 7 years' time, 10 years' time, sometimes 15 years' time, your other side of the knee, that is the side of the knee that has not being replaced, can start developing arthritis, and you might need to then replace that part of it. So that means taking the partial knee out and giving a total knee replacement. I always take patients to the National Joint Registry, and I'll give you the percentages there, so that you can make your own decisions. The most important thing is to know where your symptoms are. If your symptoms are only in the front of the knee, like a patellofemoral replacement, or if your symptoms are only on the inside of your knee, and if all your ligaments are intact, then one should always consider a partial knee replacement. But I ultimately leave it to the patient to decide, after giving all the explanation, whether they would like to have a partial or a full knee. Robotic replacement surgery is a relatively new intervention. We have been doing this for about, when it's a relatively new do you want to chat again, or okay?
Yes, please. It would be better if we can restart this one.
Yeah. So robotic hip or knee replacement is relatively a new intervention. When I say relatively new technology, that has been there for about 10 years, but in a specialty like ours, to get the clear-cut advantages, we are looking at a prolonged period of monitoring what happens. In my personal data collection, I certainly do all my knees robotically or navigation, depending upon which set of instruments are available, depending upon the geographical area where I work. Partial knees or patellofemoral knees, I I always use navigation or robotic surgery. The advantages of using partials, by use of robotics in partial knees, I can understand, and I strongly believe in that. The advantages of using that in a full knee, only time can tell. In my hands, the patient satisfaction data of my data I have looked at is slightly higher in navigation or robotic surgeries. As far as hips are concerned, so it is a good technology in knees. As far as hips are concerned, I think there's not a lot of data to show that it is a better technology, but it's an evolving technology. One has to understand whether you do navigation or robotic surgery. It is still done by the surgeon. Every decision is taken by the surgeon, and the surgeon is not in the next room. So I always reassure that in my books, I use navigation or robotic technology as just a guide to help the process. And the analogy I always give to the patients is it is like using a sat nav, but at the same time, I'm very familiar of using the map also. A hip replacement surgery is a fantastic operation. 95% of patients are very happy with their hip replacement for rest of their life. There are risks. The risks are less than 5%. It also depends on what your medical comorbidities are, but the risks are infection, bleeding, nerve damage, periprosthetic fracture, leg length discrepancies, dislocations, and stiffness. Overall, if you have got good going arthritis, the risk versus benefit ratio over the benefits are far more than risks. But one has to really consider these risk factors and understand them before going in for a surgery. Though the risk factors are small, the changes that the effects of them in your life could be proportionally higher. I go through each and every risk factor. I'll give you the percentage of risk factors, so you can make a decision yourself whether you would like to go through the process or carry on the way you are. You can have a hip injection if you want to. They are temporary, but it does help to buy you time to make a decision.